Thank you so much. It's my great pleasure and honor to introduce Dr. Ivan Kailash, who is the recipient of this year's Life Achievement Award. We all know Dr. Kharasch as an editor-in-chief of anesthesiology, and I'm not going to do justice for him just to read what's here about his achievement. But this is just, snapshots of his achievements in his life. He is a Russell and Mary Selden Professor of Anesthesiology and Professor of Biochemistry and Molecular Biophysics at the Washington University of St. Louis. He is also a founding director of the Center of Clinical Pharmacology and a joint venture between St. Louis College of Pharmacy and Washington University in St. Louis. Dr. Kharasch leads an active research program in basic, translational, and clinical pharmacology, and he is a practicing anesthesiologist as well. His research focuses on anesthetic and analgesic drugs, drugs of abuse, and addiction therapies, towards the goal of understanding hepatic and extrahepatic drug metabolism and drug transport, pharmacokinetics, pharmacodynamics, pharmacogenetics, toxicity of drug interactions, and variability in patient response. A major area of focus is the development and application of nanotechnology-based platform for rapid development of diagnostic assays for cardiac, renal, and infection disease, with applications including point of care and low-moderate income for low-moderate income countries. This includes a non-invasive biomarkers, which you all need for population screening and differential diagnosis of kidney cancer. He holds several patents for these technologies, which he is currently seeking commercialization. Dr. Kharasch is an author of more than 250 research papers, as well as numerous book chapters, and he is the editor of 2 major textbooks on anesthetic pharmacology. He has received John Silverheiser Award for Translational Research and the Excellence Research Award from the American Society of Anesthesiologists. And he is a mentor and the Mentoring Excellence in Research Award for the Foundation of Anesthesia Education and Research. And one other reason that we decided to give Dr. Kharasch this award is that we have not seen him for so many years, and the only way to bring him back is to give him an award. Dr. Kharasch.
Mohammed, thank you very much. I'm not often short on words, but I might be. I haven't been at the meeting for a decade because FAIR holds all of its business meetings on Friday, and I've been involved with FAIR for 10 years. And I just completed my term of community service. And was planning on coming back to the meeting, so you didn't have to give me an award to get me back here. But receiving an award from your colleagues is the highest honor. And the community of anesthetic pharmacologists really is my peeps. And so this has a tremendous amount of meaning for me. And I'm very honored and I'm very appreciative. When I was told that I was going to be given the award, the first thing I did was check it out and learned who else had been given the award. And this is a very august list of people in the specialty with an incredible degree of accomplishment. And Groucho Marx said he didn't want to be a member of any club that would have him as a member. But this is a club that I'm very proud to be part of. So thank you very much. I also looked up the criteria for the award, and it talked about contributions in patient care and contributions in teaching and research. So I thought I should probably talk about contributions in research. Before I do that, I just want to talk about my disclosures, and they're pretty minimal because I shed them when I became the editor-in-chief. I do a little work for a local company in St. Louis that does mass spectrometry. So those are my disclosures, but for those of you that know me, I have minimal disclosures, but I have a lot of biases, I'll share one with you. And in reflecting on where we are today, I started my career when we didn't treat chronic pain with opioids. And then there was a massive pendulum shift back to treating pain with chronic opioids. And now we're seeing that pendulum shift back. And I think that as that pendulum shifts, it's important to remember that we need to be thoughtful and rational about how we approach the problem and not reactive. While also I learned today as I was listening to some of the presentations that since I did have an anesthetic as a neonate, I should be really worried. And then I felt better because my first job was in a women's shoe store. And I thought, well, maybe it can turn out okay. While I have your attention, a little shameless self-promotion along the lines of this morning's theme on opioid pharmacology, just to remind you that the Anesthesiology Journal Symposium on Frontiers in Opioid Pharmacology is Sunday morning, and the two plenary speakers are Nora Volko, who's head of the National Institutes of Drug Abuse, and Laura Bond, who is the foremost investigator in the world in the area of biased signaling of opioids. So I think we're going to learn quite a bit. So along the lines of teaching and research, I said that I've thought back, and I've been very fortunate because I didn't have to go look for problems. Problems came to me. And it's really been the pursuit of the solutions to those problems which has resulted in an interesting path. So the paths of teaching and research actually started pretty early. And one of the things that I learned very early on is that I like to lecture. But I also learned that not a lot of people are impressed. I also started early in the science business, and when you do these things, it's always good to put the embarrassing pictures in yourself, not let somebody else do it. So I did start early, and that was the 1960s, and I continued in the 1970s. And continued through to the 1980s when I was in graduate school, and noticed the personal protective headgear that we wore while doing experiments. And science was not all serious. We had some fun doing science. We had laboratory meetings in interesting places. You'll recognize Mark Dershowitz. Mark and I shared a lab together in graduate school, and we've enjoyed a 40-year friendship since then. And fast forward a little bit more recently to my current lab, where personal protective headgear is still extremely important. The other interesting way that I marked time is with the Sigma catalog. And so I went back and looked at Sigma catalogs over the years. And these are many generations of the Sigma catalog. And when you're a biochemist, you sort of live and die by the Sigma catalog. The first Sigma catalog there is when I started my career, and obviously the Sigma catalog on the right is what it looks like today. And this is the 45th anniversary of the time when I founded my first wet biochemistry lab. So it's been an interesting journey. I think that what I learned is that the most important aspect of that journey is people and opportunities. And it's opportunities given and opportunities granted. And I was very fortunate to have a thesis advisor in graduate school who let me off the leash very early on and really didn't tell me what I couldn't do. And that's one of the things that I learned is incredibly important, is don't tell people what they can't do. I had several people when I went to the University of Washington for residency. I was very fortunate to be able to take a year off in the middle of the residency and talked my chair and a faculty member into letting me do that, to pursue a research question that we knew was hot and somebody else would get to it if I waited. And they let me do it. I worked with some incredibly supportive people. My first day as an attending was also my first day on call. I was standing in the hallway about 4 o'clock in the afternoon with Andy Bowdle, who's in the middle, and Peter Freund, who is the division chief on the right. And we were talking, and one of the surgeons came up to me and said, "You're on call, right?" And I said, "Yeah, why?" He said, "Well, we have an aortoenteric fistula that we need to do." And Andy and Peter cracked up laughing, turned around, and walked away. Got kicked out of the nest. I worked with a number of people at Seattle. When I took a job there, Tom Hornbein, who was my chair, said, "Look, we don't do what you do in this department. You're going to have to find some people to work with." And I walked over to the pharmacy school and found an entire school full of people who wanted to work with me and with whom I got to work. And my labs were in the pharmacy school for a great many years. And these are people who taught me a tremendous amount and were colleagues for a number of years. Bill Traeger, who's right here, was somebody who I decided I wanted to work with. And I spent a tremendous amount of time talking to Bill when I was interviewing for faculty positions and explained to him that I'd been out of the lab for 3 or 4 years and that I really needed sort of a mini postdoc, and had these long-winded explanations and conversations, and we had the whole thing set up and took my boards and went on a 2-month vacation, came back in the fall and said, "Okay, Bill, I'm ready to start my postdoc." And he said, "Well, come on, let's go to the lab." And he and I walked to the lab, and he put his arm around me, and he said, "You're a smart guy. Go do it. Postdoc's done." And that was an incredible vote of confidence, and worked out okay. I've had 3 very supportive department chairs over the course of my career. And I know that very often things happen in the background and strings get pulled and conversations get had, and you never know that they happen other than the fact that you really quietly, deep down, know that something good happened. So I'm very grateful to the 3 of them who made those things happen. I had the opportunity to work with phenomenal people. I left, when I finished medical school, I loaded up the truck and drove out to Seattle, initially to train, and then I stayed on the faculty for 17 years and worked with really spectacular people. Had the opportunity to host some visiting professors. One of them was Ola Dale from Norway, and Ola taught me all of the various body orifices that you could put drugs into. And that turned into some very interesting adventures. And then after a number of years, it was time for another adventure. So we loaded up a Winnebago and drove the Oregon Trail backwards from the Northwest to St. Louis, and have been there for 12 years. And there's a theme. You'll notice that the arch in St. Louis kind of looks like Mount Rainier. But I had the opportunity to, again, work with a number of smart, talented people, and it has been an absolute joy and pleasure to do that. I kind of made a map of the people with whom I've worked and published. And it's a phenomenal network of people. And this is really what it's all about, is those connections and the productivity and the enjoyment that comes from putting teams together and working on projects like this. We've also been extremely fortunate to be funded. Everybody needs a patron. Everybody needs a sponsor. I started out my career with fair funding and funding from IARS, and we've enjoyed federal funding both from the DoD and the Veterans Affairs as well as NIH. I've also worked with a number of drug companies over the years. But as I think about what we do, it's basically translational and clinical pharmacology. Most people talk about translational research as being a linear process. I kind of think of it as a sphere, because on a sphere you can get anywhere from one place to another very easily. And that's really the way that we've driven the research, is that we go all over the place, and that's really the path. It's not linear, it's non-linear. And what we've tried to do is four things: maximizing therapeutic benefit and safety, minimizing toxicity, understanding the mechanisms around what we do, and ideally having a positive impact at scale. And we've done this in a number of different areas. And over the years, we developed a sort of what I call a translational approach. When we do drug metabolism, when we do drug transport, it's more or less the same thing. We do a lot of in vitro studies, and almost everything we do focuses on human pharmacology in one way or another. We start out with expressed human enzymes. We use tissue subcellular fractions. We use hepatocytes. And then we try and take everything and replicate it in clinical investigations. And then more recently, we've done the same thing looking at drug transporters, where we clone and express a number of human drug transporters, look at cell systems, and then ideally take this into clinical investigation. So the story kind of started out with alfentanil, and while I was a resident, there was a paper published, the first one on alfentanil, and an editorial that says heralding alfentanil as a kinetically predictable narcotic analgesic. And then very shortly thereafter, Dennis Fisher wrote an editorial that said, "Are the pharmacokinetics of alfentanil really predictable?" Because they were anything but predictable. And Margaret Wood wrote an editorial talking about this and the variability of drug response. And she says that although we've got some mechanisms of variability worked out, the variability seen with alfentanil is still unexplained. And the ability to predict the response in any particular patient remains poor. So I thought this was an interesting problem and would be a good place to start. So I wrote an NIH grant. And the specific aim was to elucidate the mechanism of individual variability in the pharmacokinetics and response to alfentanil. And I was really proud of myself, and I thought that was a really great research question. And I sent it off to the NIH, and the pink sheets came back. And the pink sheet said, "This is a well-designed proposal. But the problem is we don't think alfentanil is a good drug to study because there's too much variability in its kinetics." And I was inspired. Fortunately, the Foundation for Anesthesia Education and Research saw differently and came to the rescue and threw a few dollars my way to actually start addressing the question. And this is really sort of when the green flags dropped and the start began. So let me take you on that journey a little bit. I'll go quickly because you already know most of this, but there are some highlights. So we approached this, first of all, by trying to identify the cytochrome P450 enzyme that's responsible for metabolizing alfentanil. So we cloned and expressed all the various human enzymes, and we look at them one at a time, and we feed a drug to each of these various enzymes, and then we look to see which of these enzymes makes the metabolite. And it was pretty straightforward. Now, this is a point where cloning and expressing enzymes was not the sort of thing you did between Monday and Tuesday. We also had a liver bank of human livers, and this was pretty new at the time. So we looked at the effect of a bunch of P450 isoform selective inhibitors on the metabolism of L-fentanyl by human liver microsomes. And we took an inhibitor that was specific to each one of these P450s, and we fed the drug to various liver microsomes and then looked to see which inhibitor would shut down metabolism. And then we looked in the human liver bank, we looked at a wide range of liver metabolizing activities, and we looked at the content of a particular P450 in that liver bank and correlated that with the metabolism that we saw, and that in turn told us what enzyme was responsible for metabolism. But the question was, can we do this in vitro? And this was really sort of a big transition when sitting around one day talking to Kenny Thummel, one of my collaborators, where we had done all the in vitro studies, and I said, hey, why don't we do this clinically? And he was a PhD, and he says, you can't do that. And I said, yes, we can, and yes, we will. And we did. So we took the exact same approach in vivo that we did in vitro. We got a bunch of human livers, only this time they were in graduate students and undergraduates. And we approached the problem the same way that we did in vitro, but now we did it in vivo. And we gave them all L-fentanyl, and we gave them all specific inhibitors of various P450s, and looked to see which of the inhibitors shut down metabolism. And it worked. And then we took populations of graduate students and did the same thing and looked at their liver activity and looked at metabolism and did these correlations as well. And it worked. So now we had this very nice paradigm of in vitro, in vivo studies, and that's what we called it. And this was years before somebody coined the term translation, but we were actually doing translation. So we showed that L-fentanyl was metabolized by P450-3A in vitro. It turned out that P450-3A had some genetic polymorphisms, so we looked at those polymorphisms, and we showed that if you had a deficient P450-3A, you metabolized L-fentanyl less. If you were an expressor of high-activity enzymes, you metabolized L-fentanyl more. And then we did the in vivo experiment, and we showed that the clearance of L-fentanyl in a large number of people correlated very nicely with the activity of P450 in their liver. And we also learned that L-fentanyl was exquisitely susceptible to drug-drug interactions, which explained in part why it was so kinetically unpredictable. That and the amount of P450-3A that people had in their liver and their genetics and drug interactions accounted for all of this clinical variability. But we also learned that it's not just a bug, it's a feature. We could use the variability and the extreme dependence of L-fentanyl on 3A activity as a way of measuring people's 3A activity by their clearance of L-fentanyl. And that turned out to be very utilitarian. Now, we all know that opioids decrease pupil diameter, so we asked the question, can we use pupil diameter as a surrogate for plasma L-fentanyl concentrations? And we're not ready to throw away the mass specs yet, but could we get very quick, real-time answers to drug disposition? And so we did this. So this is a graph that shows plasma L-fentanyl concentrations in red and the change in pupil diameter in blue. And what you'll notice is that they track incredibly well. So we could now use L-fentanyl and meiosis from L-fentanyl as a surrogate for plasma concentrations and as a non-invasive assessment for L-fentanyl disposition and a non-invasive assessment for the activity of P450-3A and in the liver and in the gut. So we think that we shed a lot of light on the pharmacology of L-fentanyl. We provided some information that enabled people to avoid toxicity, and we were also able to provide information which shed some light on the mechanism. Another path that developed was one dealing with inhaled anesthetic agents. And this started when Kenny Thummel, this collaborator in the pharmacy school, came into my office one day, and he said, I have an interest in one of the P450s, 2E1, and one of the substrates for it is this drug called Fluorine. And I hear you're an anesthesiologist. Do you know anything about Fluorine? And I said, yes, why? And he told me, and we started working together. And what resulted from that was a 25-year incredibly productive collaboration, as well as an incredible personal and professional friendship. So we started out, and we showed that the rat finding could be replicated in humans, that P452E1 did metabolize enflurane. And he said, well, that's great, we're done. And I said, not so fast. I said, because we also have isoflurane, desflurane, and halothane. And we looked at the metabolism of those anesthetics and showed that they were all metabolized by 2E1 as well. Sevoflurane was in development at that point, and I went over to Japan and had some conversations and came back with some sevoflurane, and we were able to look at sevoflurane as well and show that it was metabolized by P452E1. And one of the aspects of this was all around halothane. We were still in the era of halothane hepatitis. And people knew that metabolism of halothane was responsible for toxicity, but nobody knew what was metabolizing halothane. So this really shed light on the whole mechanism of halothane hepatitis. So at this point, we took our in vitro paradigm and we replicated it in vivo. And we did this with halothane as well as some of the other drugs. And what's shown here is the plasma concentrations of the major halothane metabolite, which reflects toxicity, and that we could shut down the metabolism by inhibiting P452E1, which told us two things. One was that was the enzyme that was responsible for halothane hepatitis. The other was that if you're using halothane, you can pre-treat subjects with the inhibitor, which is disulfiram, antabuse, and you could largely prevent most of the metabolism that's responsible for the toxicity of halothane. Not necessarily important in North America, but still a drug that was very widely used in the third world. And so what we learned was that halothane, enflurane, and isoflurane, and sevoflurane were all metabolized by P452E1 clinically. Around this time, the first clinical studies with sevoflurane were being done. And one of the early observations was that plasma fluoride concentrations after a sevoflurane anesthetic were very high relative to what we were used to seeing. And the reason this was a concern is that if you go back to the 1960s in the era of methoxyflurane nephrotoxicity, the conventional wisdom was that methoxyflurane caused nephrotoxicity because plasma fluoride concentrations were in excess of 50 micromolar. And every drug that had been developed subsequent to that underwent testing, and if it was metabolized to fluoride, the drug was killed. So there was a lot of concern about these elevated fluoride concentrations. Are we going to revisit the issue of methoxyflurane nephrotoxicity all over again? And the question was sevoflurane safe? And so I was involved in a number of clinical studies that looked at the question. I worked with a number of other individuals at the time who were working on the same project, and everybody saw the same thing, and that was that fluoride concentrations after sevoflurane were excessively high, excessive relative to 50 micromolar, but there was absolutely no clinical influence on renal function. And this was clearly challenging the conventional wisdom. And the question was why? What's the mechanism? As you heard earlier, you can't disprove the existence of dragons, but showing that something doesn't exist doesn't provide a lot of assurance. We wanted to be able to provide information on mechanism, because if you can provide information on mechanism, the lack of observation becomes much more assuring. So we looked at the metabolism of methoxyflurane compared to sevoflurane. And we looked at it in vitro, and we couldn't look at it in vivo because methoxyflurane was not available for clinical use. But we made an interesting observation, and that was when we looked at human liver metabolism of methoxyflurane and sevoflurane, it was very extensive for both drugs. But when we looked at the metabolism of methoxyflurane and sevoflurane by human kidneys, we found that human kidneys metabolized methoxyflurane, but they didn't metabolize sevoflurane. And this made sense because in the world of toxicology, when you have metabolism, it's almost always the organ in which metabolism occurs where the toxicity is manifested. It never made sense that methoxyflurane was metabolized in the liver, fluoride would be released systemically, and yet act specifically on the kidney. But now we had an explanation that it was renal metabolism of methoxyflurane, that it was responsible for the toxicity, and it's the lack of renal metabolism of sevoflurane that's responsible for the lack of toxicity despite systemic fluoride concentrations in excess of 50 micromolar. So it was really the observation plus the mechanism which enabled the assurance around the safety of sevoflurane, which really enabled this drug to go forward and be approved by the FDA. So again, it was this combination of maximizing safety, minimizing toxicity, and providing a mechanistic understanding around how those things happened. Around this time also was an issue of carbon dioxide absorbance, and the fact that it was shown that the carbon dioxide absorbants were degrading volatile anesthetics. In the case of desflurane, they were degrading desflurane to carbon monoxide, which obviously is a known toxin. They were also degrading sevoflurane to something called compound A. Compound A was toxic to rat kidneys, and this was concerning to the anesthesia community, but it was also of great interest to the manufacturers of desflurane, which was a competing company at the time. So the question was, how is this happening? So we looked at the mechanism by which the absorbents were degrading the volatile anesthetics, and we identified that it was the strong base, sodium hydroxide, in CO2 absorbents that was responsible for the degradation of desflurane and the degradation of sevoflurane. And we identified that if you took the strong base out of a CO2 absorbent, the anesthetics didn't degrade. Around this time, the Anesthesia Patient Safety Foundation convened a meeting in Chicago around CO2 absorbents and the whole issue of anesthetic degradation. And I was very fortunate to work with a number of very smart people in engaging in this. And it was a meeting of academic anesthesiologists and CO2 absorbent manufacturers all sitting together in the same room to work on the problem. And so we had a morning of conversation, and then it was sort of like, well, we're not quite sure where to go next. And I thought, you know, I'm not shy, so I kind of stood up and said, oh, I'll be bold. And I asked every one of the representatives of all of the CO2 absorbent manufacturers the following question. And I said, do you have or are you developing a CO2 absorbent that does not have strong base? And every one of the manufacturers said yes. It's not public, but we'll admit it here. And so I made a proposal that the APSF should sort of come out with a statement about the use of these absorbents, and the APSF was rather upset because they said, we don't make rules for manufacturers to follow, and they provide us with our funding, so we can't diss them. And so I said, well, let's ask the manufacturers how they feel about this. And we set out the following statement, that APSF recommends the use of CO2 absorbents whose composition is such that exposure to volatile anesthetics does not result in significant degradation of the volatile anesthetic. And we asked every manufacturer if they would stand behind this statement, and they did. So the APSF published this statement. And this completely changed the use of CO2 absorbents in the operating rooms in which we work. So again, working to maximize safety, understanding mechanism, and having impact at scale. At the same time, there was a lot of concern about compound A, because compound A was nephrotoxic in rats. The question is compound A formation during sevoflurane anesthesia a safety question? and therefore is sevoflurane safe to use? So I had the good fortune to work with a number of other investigators on a number of clinical studies, as well as we did a number of studies in our lab about the mechanism by which compound A caused renal toxicity. And what we learned is that low-flow anesthesia, where compound A concentrations are highest, is not nephrotoxic in humans. No matter how much compound A we generated in clinical studies, we never saw any issues having to do with renal function. And the question then is, that's a great observation, but why not? And what we learned was that compound A toxicity was caused by the metabolism by a certain enzyme in the kidney called beta lyase. So then we went back to our human kidney bank and looked at the activity of beta lyase in human kidneys compared to rat kidneys. And what we learned was that the metabolism of compound A by rat kidneys is very different than the metabolism in human kidneys. Rats are not humans. So again, it was really the observation and the mechanism which provided a great degree of assurance, and the FDA approved sevoflurane. So I think that in terms of trying to have impact at scale, I think that we and all the people who were working on this had impact at scale. There have now been about 1 billion sevoflurane anesthetics given worldwide to date. So I think we accomplished the goal of impact at scale. Another project that we worked on is with one of my favorite drugs, methadone. Methadone has a lot of kinetic variability. And there was a lot of data showing that it was metabolized by P453A in vitro. And the FDA, interestingly, took that in vitro data and wrote a package label on the clinical use of methadone based on the in vitro data. And the FDA said, methadone's metabolized by CYP3A in vitro, and then they said the clearance in vivo must be determined by CYP3A, and that CYP3A, inhibition of CYP3A will decrease methadone clearance and be a risk to patients. And this was in the methadone FDA label for a great many years. Every practitioner guideline around the use of methadone warned about metabolism by CYP3A and CYP3 drug interactions. And that was a pretty significant extrapolation. So we asked the question, what happens clinically? And the answer was, it was a black box. There was absolutely no information. So these are clinical practice guidelines written based on test tube data. So we spent about 10 years looking at the metabolism of methadone clinically. And I'll summarize a lot of that work in a single slide. So this slide compares the activity of P453A to the clearance of alfentanil. And this is a series of drug-drug interactions, and we probe this by drug-drug interactions. So the bars in red show the activity of P453A, and bars that go down show a decrease in activity. The bars in blue and yellow are the clearance of methadone, and bars that go up are an increase in clearance. And what you see is that throughout almost every one of those drug interactions, we could inhibit the activity of P453A by up to 97%, but we doubled the clearance of methadone. So very clearly, this told us that methadone was not clinically a P453A substrate, and that the clinical guidelines and in the FDA package label clearly needed to be rewritten. But the question then was, what is metabolizing methadone, and what is responsible for methadone clearance? So we went back to our in vitro paradigm, and we identified another enzyme in human liver called P452B6, and then we did some clinical studies and identified that 2B6 was responsible for methadone metabolism and clearance. So here is a similar kind of a plot where now the red bars show the activity of P452B6 and the blue and yellow bars show the clearance of methadone. And what you see is that when we up and down regulate P452B activity, we up and down regulate methadone clearance. So told us that, again, the FDA label for methadone needed to be rewritten, and we we were able to inform better on clinical practice. More recently, we got involved in the genetics of methadone metabolism in P450-2B6, because 2B6 is a very polymorphic enzyme, and the question was, do genetics influence the metabolism and clearance of methadone? And we cloned and expressed a number of these variant enzymes and did the laboratory experiments, and lo and behold, we identified one of the 2B6 variants that was a deficient metabolizer in vitro. So we did a clinical study, genotyped about 500 subjects, assembled genotyped cohorts, and looked at the metabolism and the clearance of methadone in these specific genotyped cohorts. And what we showed was that if you carried what's called the star 6 allele, you were a poor metabolizer of methadone and would have higher plasma concentrations. If you carried a star 4 allele, you were a super metabolizer of methadone and would have lower plasma methadone concentrations. And the clearance values are shown on the bottom, the plasma concentrations are on top. And what you find is that, yes, 2B6 genetics really does influence the disposition of methadone, and this in part accounts for some of the population variability that we see in the kinetics of methadone. And you know, I think the end of the story is that the FDA has changed the package label for methadone. It now talks about methadone metabolism and clearance by P450-2B6. And that it is this enzyme that is responsible. So again, I think we've been able to really inform on the clinical use of the drug, improve how it's used, improve practitioner guidelines, and understand the mechanism and hopefully have impact at scale. We also got interested in the pharmacodynamics of methadone, because in all the studies that we were doing, we were measuring drug effect as well as drug concentration. And what we learned was that many of our drug interaction studies were shifting the pharmacodynamic curves for methadone. And that was an interesting observation, because it suggested that there was some type of transporter interaction at the blood-brain barrier, which also said that there had to be some transporter at the blood-brain barrier that's responsible for moving methadone in and out. And that got us interested in the whole question of opioid transport at the blood-brain barrier. Now, at the time, people tended to think of the brain as a giant lipid sponge. And if you made drugs lipid soluble, they soaked into the brain. If drugs were water soluble, they didn't soak into the brain. But what's come to be learned since then is that the blood-brain barrier is really a very active barrier. There are transporters which move drugs into and out of the brain. And there are some drugs which very avidly make it into the brain, but they're so quickly pumped out that they don't have a pharmacologic effect. Loperamide is a perfect example of a drug like that. Loperamide is a spectacularly good opioid, and it gets into the brain very easily, but it's so quickly pumped out that there's no biological effect. So we asked the question, what happens if we start to manipulate some of these transporters at the blood-brain barrier? We focused on one of the transporters called PGP, or P-glycoprotein, because at the time people thought that PGP was responsible for all of this. And plus the fact, if you wanted to get funded, you have to propose that it was a PGP mechanism, so we did. We did some interesting studies, and here I got to work with Konrad Meisner, who's a visiting professor down in St. Louis, and we did some interesting clinical studies together. We said, let's take a clinical inhibitor of PGP. Cyclosporin happens to be that kind of an inhibitor, and see what the influence is on opioid pharmacodynamics. So the paradigm was a 2-hour infusion of cyclosporin followed by a 1-hour infusion of opioids. And this paradigm didn't affect drug concentrations at all, but it really did influence drug effect. And here we were using morphine as sort of a control, if you will. And this is meiosis, change in pupil diameter as a function of time. And what you notice is that cyclosporin had no effect on methadone, but it did have an effect on morphine. And Mike Avram helped us in this experiment in terms of the data analysis and really understanding the kinetics at the blood-brain barrier. And we learned that inhibiting PGP at the blood-brain barrier did enhance the penetration of morphine into the brain. It didn't enhance the penetration of methadone. So it didn't tell us what was moving methadone back and forth, but we didn't think it was PGP. So we did a reverse translation experiment and cloned and expressed PGP in the laboratory and looked at the transport of morphine and methadone by PGP in the laboratory. And in the world of drug transport, we express things as a transport ratio. If a drug has a transport ratio higher than 2, we think it's a substrate. If it's less than 2, we call it not a substrate. And morphine was just barely a substrate, and we learned that methadone was not a substrate. So again, this informed on a little bit of mechanism in terms of understanding what we were seeing. And then the other opioid which has gotten us interested lately is buprenorphine. Buprenorphine, again, has a lot of kinetic variability. It has a lot of active metabolites. There was evidence that it was metabolized in vivo or in vitro by CYP3A. And the question was, what happens clinically? Is this going to be the methadone story all over again? So we went and did the clinical study and looked at buprenorphine metabolism, and we up and down regulated the activity of P450-3A. And the slide up, or the graph up top shows you plasma concentrations of buprenorphine and norbuprenorphine, and what happens when you inhibit P450-3A. And the results were a little bit squishy, and we didn't quite understand it at first, but one of the things that you notice is that the metabolite concentrations are actually quite high. They're not low, they're quite high. The other thing was, when we looked at some of the effect curves, even though the buprenorphine concentrations in the presence and absence of CYP3A inhibition, which is the blue lines in the top graph, those were relatively superimposable, we did see some changes in the pupil diameter change curves. And we really saw some differences in the analgesic effects of buprenorphine. So it got us to wonder, is norbuprenorphine an active metabolite? Could this be responsible in part for some of the effect of the parent drug? So I worked with one of the postdocs in my lab, Sarah Brown, a really smart, intrepid individual, and she did some interesting studies. She did some receptor binding studies looking at buprenorphine and norbuprenorphine, and she showed that at mu and kappa opioid receptors, norbuprenorphine was just as good a drug as buprenorphine. And then she did some experiments with norbuprenorphine in mice. It's the only mouse experiment that I've done in decades, because we couldn't quite do this yet in humans, and she showed that norbuprenorphine had effects on respiratory depression. So clearly we're dealing with an active metabolite, at least in animals. And the question was, what happens in humans? Is the metabolite biologically active? So we were able to work with a local company that made us norbuprenorphine. And we did the first-in-man clinical investigation with norbuprenorphine to ask the question, does this metabolite have pharmacologic activity, and can this inform on what we see with buprenorphine? So we did 1-hour infusions of norbuprenorphine. We did arterial and venous plasma concentration measurements, and we quantified the amount of norbuprenorphine as well as norbuprenorphine glucuronide in plasma. And we did this at doses sufficient to resemble the doses of norbuprenorphine that you see when you give buprenorphine. And what you see is that we get really nice kinetic curves. Glucuronide concentrations are relatively high. They peak a little bit after the parent drug concentrations, but there's some really nice kinetics. We also looked at drug effect. And norbuprenorphine caused meiosis, just like any other mu agonist. Norbuprenorphine caused respiratory depression. The green shows you end-expired CO2, which goes up, respiratory rate, which goes down, just like any other mu agonist. And we also looked at analgesia, and we used thermal testing. Now, normally, if you give an opioid and you're doing thermal testing, the tolerated temperature goes up. here, the tolerated temperature went down. So norbuprenorphine is actually anti-analgesic, not analgesic. Not a typical mu agonist. So there's something else going on with norbuprenorphine. But it also tells us that some of what we see with buprenorphine is probably contributed to by norbuprenorphine, and some of what we see may even be antagonized by norbuprenorphine as well. But the other thing about the pharmacokinetic curves is that they were very complicated, and I quickly realized that I didn't understand them. And one of the fun things about science for me is that I use it as an excuse to work with people with whom I like to work, frankly. I'm very selfish that way. So I roped Tom into helping us with the modeling on norbuprenorphine. And Tom has constructed an exquisitely lovely model for norbuprenorphine with both arterial and venous kinetics, and including parent drug and metabolites, and including urine excretion, and then extending that to the pharmacodynamic model for every one of the clinical readouts that we have for this drug. And once that is all done, we will be able to take that model and feed it back into the model for buprenorphine to better understand the pharmacology of the drug where we started. And he spent just tremendous amounts of time on these fits. Each one takes 8 hours to do. This is a Herculean effort. And these curves are so nice that I wanted to show them. And so there's arterial sampling for 12 hours and then venous sampling for as long as 96 hours. And the models fit really well. There's also the pharmacodynamic models. And again, for meiosis, respiratory depression, and anti-analgesia, not analgesia. So this model, I think, helps us better understand the pharmacology of buprenorphine. So we heard today that we are in the midst of what has come to be called an opioid epidemic or an opioid crisis. And I've sort of teased this out into 3 challenges. One is the challenge that we face in the operating room. One is the challenge of analgesia. Despite everything we've done and learned and do, 80% of patients still say that their surgical pain is not adequately treated. And we have a 10 to 50% incidence of chronic postoperative pain, and acute postoperative pain is the greatest risk factor for chronic postoperative pain. The second challenge we have is one of postoperative respiratory depression. We all know it, we all see it. Every major hospital has adverse events as regards postoperative opioids. The risk has been quantified recently as about 1.4 deaths per 100,000 patients. And given the fact that we do tens of millions of surgical procedures every year, you can do the math. The APSF has said that no patient should be harmed by opioid respiratory depression, and I don't think any of us disagree with that. And then the third problem that we face, which is new, is the opioid epidemic. It's been said that the United States is awash in opioids, and the problem is diversion, misuse, abuse, and overdose. 28,000 deaths annually, and we've learned that there is overprescribing of postoperative opioids. Everybody gets 30, 45, or 60 tablets to take home, regardless of what they need or what they might use. So we've gone back to methadone, which is sort of an old friend. And this is some work which Helga Koman's done, who's in St. Louis for a few years from Croatia. Starting with the premise that methadone was shown back in the 80s, and since then in some other clinical studies, to provide better analgesia and decrease post-op opioid consumption. The question, and that was all in inpatients. And the question is, what happens in outpatients? So I used to get asked this question, and I said, there's no data. And after many years of saying there's no data, sat down with Helga and said, why don't you go get the data? And she has. And so in a dose-finding study in same-day surgery outpatients, looking in a dose escalation paradigm, to ask the question, is methadone utilitarian? Does it work? What's the right dose? And the answer is yes, it does. And the right dose is about 10 milligrams. So this is a series of slides which, as a function of dose, show you the amount of non-methadone opioid that patients need, either if they didn't get methadone or they got 0.1 or 0.15 milligrams per kilo of methadone up front at the beginning of surgery. And what you see is that if you get a single dose of methadone, you need far less intraoperative opioid. The graph on the right shows that if you get an intraoperative dose of methadone, you need less opioid in the recovery room. And the bottom panel shows that if you got an intraoperative dose of methadone and looked at how much opioid did you get during the entire time that you were in the hospital or the surgery center, how much opioid did you need? And what you see is that a single dose of methadone at the beginning of surgery decreases opioid requirements. Now that's day of surgery. The other question is, what about beyond day of surgery? Is there any other benefit? And the answer is yes. Helga sent surveys home with patients to ask them every day for 30 days about their pain and opioid use. And what you can see is the black squares are the control group that just got fentanyl. The red circles are the group that got 0.15 milligrams per kilo of methadone. And this is their 30-day pain scores. Single intraoperative dose of methadone. And you can appreciate that patients had significantly less post-operative pain. The greatest effect, not surprisingly, is the first week, because that's when most patients have pain. They generally don't have pain beyond 7 days. So single intraoperative dose reduces 30-day post-op pain. She also looked at post-op opioid consumption. And what you find is that 30-day post-op opioid consumption is also diminished by a single intraoperative dose of methadone. So the thinking is that if patients use less and need less, surgeons will prescribe less, and there will be less left over in medicine cabinets for diversion and misuse. So again, working towards the idea of maximizing therapeutic benefit and safety. Along the way, I've had the opportunity to work with people on other projects. Andy Bowdle and I, when I was out in Seattle, wrote a textbook of anesthesia. I was a relatively junior faculty member, and Andy and I had a long-standing, great working relationship, and he came to me one day, and he said, I got this letter from a publishing company that wants somebody to write a textbook of anesthesia. Do you want to write a textbook of anesthesia with me? And I always had a rule that you should never write a review article or a textbook if you're an assistant professor. And I said, Andy, I'm not interested in writing a textbook of anesthesia, but if I were to write a textbook of anesthesia, here's what I would do. And I sort of went on for 20 minutes. And he said, great, thanks. And a month later, he comes back and he says, guess what? We're now in the textbook of anesthesia business because everything that you said I wrote down and sent back to the publisher. And they want us to write a textbook. So be careful what you say. So we wrote the book on the left, and then when I moved to St. Louis, Alex and Mervyn, who had written the first edition of their textbook, asked me to join them and to write the second edition, and we had a lot of fun. A great excuse to work with great people. I also had a couple of other hobbies along the way. I did 5 years as what I call community service as our university's vice chancellor for research. And again, that was the opportunity to have impact at scale and really influence the research direction of a major institution. After I did that, I founded what is the Center for Clinical Pharmacology, which is a joint venture between Washington University in St. Louis and the St. Louis College of Pharmacy, which is a completely separate independent institution, but in many ways it recapitulated my roots back in Seattle when I worked with the pharmacy school. I picked up another hobby as the editor-in-chief of anesthesiology. And if you'll notice the painting on the left, I think it very well represents what people say, well, what's it like to be the editor-in-chief? And I think this painting depicts very well what that experience is like. And there is now a tradition that this painting will be handed down from editor-in-chief to editor-in-chief. I also had an opportunity to work with my predecessors, Jim Eisenach and Mike Todd, and their roles as editors-in-chief, and it was just a wonderful opportunity to work with spectacular people. So this is my story, and in some ways, I didn't drive this. We just went where the science took us. We approach translation in a little bit different way than some people do. It's not a linear function. We've tried to maximize therapeutic benefit and drug safety. We've tried to minimize drug toxicity. We've tried understanding the mechanisms by which these things happen, and we've tried to have the greatest impact we could at scale. And really what it's been is a number of opportunities that we were able to take advantage of. We use those opportunities to work with spectacular people and to work in spectacular teams. And so speaking of people, I showed you slides of people that have been very important in my life. I wanted to save the best for last. My wife, Karen, who's been on the journey with me. And I was delightfully surprised to learn that my sister and my niece were coming today to hear this. And I figured out that for decades they've been asking me what I do. And I always dodged the question. And now they cornered me because I couldn't dodge the question. So now you know what I do. But it means a tremendous amount to me that you came, and I thank you very much. And I thank the Society for this award. I don't consider this an award for crossing the finish line because we haven't crossed the finish line, but I consider it an award for making it around the track a couple of times. And it's been a great venture. And as I thought about this, a line from a Grateful Dead song came to me. Lately it occurs to me what a long, strange trip it has been. So thank you very much for the honor.